Okay, now we're going to start our GI series. So this is chapter 46, 47, 48. So I'll break it down into 3 different lectures just so that each one is not too terribly long. So let's start with chapter 46 and we'll go over the oral and esophageal disorders. The first thing that you need to know when you're doing a physical assessment, you're just going to assess your patient's mouth. You're checking for mucous membranes, you're checking that those membranes are all intact and that they're moist. One thing that I wanted to point out, if you see, this is called leukoplakia. Leuko is the word meaning white, plakia is plaques. White plaques or hairy leukoplakia, where it's the same thing but it's just a little bit more, have got hairy-like structures on it. If you see these findings in your patient, make sure that they're using good oral hygiene, that they're brushing their teeth, they're flossing. Check and find out what they're eating. Are they having good nutrition? Are they eating a lot of candy? These kinds of things can be, it could just be a virus, it can just be a little bit of a stress reaction to something. But if either one of these persists longer than 2 weeks, you need to notify a physician or have it further evaluated, because it can be an indication of a malignancy. So if you find this, assess how is somebody brushing, what are they eating, and then can you improve on those things. Teach them about good nutrition, teach them about fruits and vegetables and brushing their teeth several times a day, rinsing with a good oral rinse and things like that. And if it still persists after that, it needs to be further evaluated, because it could be an indication that something more onerous is occurring, like a malignancy. Anytime your patient smokes or chews tobacco, smokeless tobacco, they are at high risk for oral cancers. So if you're doing your assessment and you're finding out that they do smoke, chew, don't have good nutrition, things like that, that makes these findings more likely that could be something a little bit more serious. Oral cancers are not good cancers to have. The people that are at risk for the oral cancers, anybody who smokes, anybody who does smokeless tobacco like chewing, those people are very high risk for getting oral cancers. Excessive use of alcohol, people that have had an infection with the human papillomavirus, the HPV, we're now seeing that there is a link between getting the HPV virus and development of oral cancers. So as you know, there is a vaccine for HPV now that we are having our young adolescents starting to get, so that might help eradicate some of the oral cancers now that the young adolescents are starting to get vaccinated for HPV. Anytime your patient does more than one of these risk factors, their risk for developing a malignancy goes up exponentially. So if they just smoke, they've got one risk factor. If they smoke plus they drink plus they chew, now they've just tripled their likelihood of developing oral cancers, and so those patients are going to be placed in a much higher likelihood that they're developing a malignancy. So what you want to do is obviously let your patient know what the risk factors are, and try to encourage them to stop those risk factors, and then do very frequent assessments on these patients, because then what you're trying to prevent is this. Now this right here has become an oral cancer. And you'll notice the difference between the leukoplakia and this. See how this is red and raised and just ugly? Cancers are ugly. They're not pretty. So this is obviously going to have to be treated. Again, this right in here is now an oral malignancy. But look at this person's teeth and his dentition. You can see here that this person's oral care is not acceptable. It's not up to standard. His teeth are not in good shape. He's got some cavities back in here. So all of these, and then when you see this finding, and especially right here, this person probably chews tobacco. Because he probably put the chew right in there, and so this is going to need to be surgically removed, which is going to leave him fairly disfigured. However, even here, see how in this person's tongue, right in here, see how this is red and raised? up in here. You got a little bit of purpley things up in here. This, again, this needs further evaluation because this too is a malignancy, because now you've got something that's beyond just that oral leukoplakia. So the oral cancers, they are fairly aggressive. They can lead to things called xerostomia, which is the medical word for dry mouth. So if your patient then has a cancer like this, they go in for surgery. Following surgery, they can have that radiation. Now, the difference between radiation and chemotherapy: radiation is a beam that will go right to the cancer spot. So anything in this way gets radiated. So if your patient has an oral cancer and it's being eradicated, that can lead to xerostomia. It can also lead to stomatitis. Stomatitis is just ulcers in the mouth. Like you would probably know them as like cold sores or cancers or canker sores in the mouth. That's stomatitis. So these two things can occur following treatment of the oral cancers. Once a patient is diagnosed with an oral cancer, the treatment of choice is surgery. So your patients who are going for cancer or surgical treatment of oral cancers requires a tremendous amount of nursing care. One, they're going to be scared because they've got cancer. Two, they're going to have anxiety because they have to go in for surgery. So you can see on this slide, all the areas here in the neck is very, very full of lymph nodes. So if a patient is developing a malignancy in the mouth, like I showed you those other pictures in here, it can easily dip into the lymphatic system. Once a malignancy is in the lymphatic system, now you're looking at chemotherapy, because chemotherapy is the systemic way to eradicate cancer that has infiltrated into the lymphatic system. This is a picture of an oral resection. This is the jaw, this is the patient's teeth, and they're having to resect an oral neck cancer. These are massive surgeries, major surgeries. You can see the not subclavian, the jugular vein coming down, the carotid artery going up. So these patients, they will open up that entire neck to take out the cancer, because they've got to get a large margin, make sure there's no cancer cells in the margin, and then they will take lymph nodes out to make sure that, to see how many lymph nodes are involved. Following this kind of a procedure requires tremendous, astute postoperative nursing care, because you've got this going on. The patient will often come back with a tracheotomy because you're going to need to protect that airway. Following this kind of surgery, the patient is going to have tremendous amount of swelling. It's right in the airway, and your patient is very high risk for airway obstruction. So they'll often come back with a tracheotomy in place. They'll often be having a nasogastric tube in to decompress the esophagus and stomach. There will be a huge incision here. They often have a drain in. That will often be like to a Jackson Pratt or some other kind of vacuum system, because what will happen is this will swell up with fluid, so you're going to want to pull the fluid off of there. So this is the outcome of having oral cancers that then need to be resected, which typically is caused by smoking and chewing. So if we can get our patients to not do that in the first place, that would be lovely. Okay, so let's talk about hiatal hernias. A hernia, when you hear the word hernia, it just means that an internal organ has pushed through a muscle. And when we're talking about a hiatal hernia, unlike like your inguinal hernias are down in your groin, an umbilical hernia is in the belly button area, but a hiatal hernia is when part of the stomach comes back up through the diaphragm. So you'll remember that your diaphragm is the organ that separates the lungs from and the thorax from the abdominal cavity. And so it's this dividing line. The esophagus comes down, and then typically, and I should have put a normal looking one here, then like the esophagus comes down like this, and then the stomach opens up like this. And that's how it's supposed to be. But in a hiatal hernia, there's two different kinds. So like this is just portion of the stomach comes back up through the diaphragm, or a piece of stomach can actually come up through a separate section in the diaphragm. These are hiatal hernias. A patient who has a hiatal hernia will have discomfort after they eat. When you're assessing lung sounds up here, you might hear some sloshing and some water here because you're actually hearing stomach contents in there. And so oftentimes the patient who has a hiatal hernia has to go in and have surgery. And what they do is they just go in through the stomach, or through the muscle in the top of the abdomen, bottom of the thoracic, push the piece of the stomach back in, and then reclose that up. Other things that you can do in your patients that have a hiatal hernia is have them sitting up after they're eating, having small meals rather than a big meal in order to keep that stomach small. So this happens in your patients who tend to be overweight, out of shape, their abdominal muscles are weak. So those are some of the patients that have gastroesophageal reflux disease for a long time can get these kinds of hiatal hernias, where this just sort of this outpouching of the stomach. So typically there are some things you can do to manage symptoms, but eventually they often have to have surgery to have that repaired. Let's talk about gastroesophageal reflux disease. Very, very, very common in the United States, known as GERD, and there are a bunch of different symptoms. So your patient will start maybe complaining about pyrosis, which is just sort of like this burning, uncomfortable sensation in the esophagus. Dyspepsia, which is like just sort of indigestion. They don't feel good after they eat. They may burp up food, or get like a little bit of like, when people say, oh, I just threw up in the back of my mouth, that's like regurgitation. Dysphagia, and now I want you to know this word dysphagia versus dysphagia. And the way that you can tell is the G kind of looks like a mouth and a stomach. So that's how I remember dysphagia is difficulty swallowing, whereas dysphagia with an S is S stands for speech or speak, and that's an inability to speak well. So that's how you can remember the difference between dysphagia, alterations of speaking, and dysphagia, difficulty swallowing. Or odonophagia is pain with swallowing. People that have a lot of salivation, they salivate a lot. Esophagitis is just sort of like an irritation in the inside lining of the esophagus. And sometimes people think they're having a heart attack. And then they will come in like with chest discomfort, they don't feel good. They think they're having a heart attack when in fact they're just having GERD. Typically with gastroesophageal reflux disease, it's worse after eating. It's definitely worse after eating a lot of food, because then the stomach is full and it pushes back up. So if you'll remember, there is a valve between the bottom of the esophagus and the top of the stomach. So when you eat, the food goes through that valve, and then it shouldn't come back up. Well, people who have GERD, some of the stomach contents come back up into the esophagus, and what's happening is the stomach contents are starting to erode the inner lining of the esophagus, because the esophagus lining is not as thick and structurally able to support the stomach acid, and then it starts eroding that esophagus and leads to esophageal reflux disease. And so there's a lot of things that we do about it. First you identify it, and then what do you do about it? So you've got to figure out how do we treat patients that have GERD. You want to eat a low-fat diet, and there's certain foods that we do know help reduce GERD, and it's not the ones that you would think. So, like for example, caffeine, yes. Tobacco, yes. They shouldn't. The people that smoke and drink alcohol are at higher risk for everything bad. But especially GERD, beer, milk, foods with peppermint and spearmint, people that have GERD should avoid that. Carbonated beverages tend to make it worse. Another thing is your patients who have GERD should avoid eating 2 to 3 hours before they go to bed, because if the stomach's full and then they lay down, now all of a sudden, now you have reduced the use of gravity. So if your patient, if they have GERD, if they can sit up after they eat, that's better. Not eat for a couple hours before they go to bed. Overweight people are at higher risk for developing GERD. Tight fitting clothes, if you've got GERD, if you like putting tight belts on, you're going to just shove those stomach contents up into the esophagus. Another thing that people can do is elevate the head of the bed. Again, that's just a gravity concept, so you can keep the stomach contents back in the stomach. We have a bunch of medications that we use for patients who have GERD. Anything from over the counter, like Tums and antacids, things like that you can get over the counter. Some things that used to be prescription are now over the counter. A lot of the H2 receptor antagonists, Zantac, Pepcid, a lot of those now you can get those over the counter, or they're generic because they've been around for a long time, so they're not as expensive as they used to be. The proton pump inhibitors, that actually reduces the release of gastric acid, and so that'll help improve the amount of gastric acid that's getting back up into the esophagus. The thing that we watch for with your patients who have gastroesophageal reflux disease is that if it's not treated and if it goes on for too long, it can lead to Barrett's esophagus. Barrett's esophagus is a continuous erosion of the esophagus, and what I'm doing here is I'm looking down it's an EGD. It's an endoscope where the patient will swallow a scope, and there's a light and a camera on the end of it, and they swallow it down into the esophagus, and it takes pictures of the esophagus. That's what this is. And so you can see here a pretty significant erosion in the esophagus. The problem with Barrett's esophagus, patients who develop Barrett's esophagus are at higher risk for esophageal malignancies. So you need to be very careful once you identify this to make sure that you are treating this aggressively with proton pump inhibitors, H2 blockers, diet, exercise, losing weight, things like that. This is a horrible picture. It looked a lot better on my computer. So this is just a picture of how they do an EGD, an esophagogastrodiagonal scope. They just go in through the mouth, down the esophagus, and they can visualize into the stomach. But I'll show you some better pictures of that. Okay, so who's at risk for esophageal malignancies? Again, people who drink and smoke too much. Those are your big factors. Ethnicity tends to occur more in African Americans, tends to occur more in males, tends to show up about midlife, around 50 to 60-year-old. People who have had a history of GERD, and certain parts of the United States tend to have higher incidence of GERD, and not just the United States, across the world there seems to be different pockets of people that are more likely to develop GERD. So some symptoms of esophageal malignancy, it's similar to GERD. The biggest difference is that patients who are starting to develop an esophageal malignancy is they will complain of like difficulty swallowing, or it feels like something's getting stuck when they're swallowing. And it will start out first with solid foods, but eventually as this progresses, even liquids, they'll feel like liquids are getting caught. The problem with esophageal cancer is there's a lot of space in the esophagus, and people tend to not recognize symptoms, and then they kind of ignore symptoms. Once they identify, they go in and say, hey, this is going on, I'm having difficulty swallowing, I'm not being able to get my food down, I'm hiccuping a lot, I've got halitosis, meaning that really bad breath because of the decay of the esophagus. They'll go in and get a diagnostic workup done, like a EGD. They'll get a piece of the tumor that's growing there and identify it as gastric or esophageal cancer. The problem is it's extremely aggressive. So once they find it, they typically will take it out surgically. They'll do an esophagectomy or a partial esophagectomy, often followed by radiation. They'll radiate the area. If it's in the lymph nodes, they'll start doing chemotherapy. However, the life expectancy of somebody who has developed esophageal cancer is typically less than 5 years. And sometimes they will do surgery or chemotherapy, radiation just for palliation, so that the person can eat or enjoy their life for a little bit longer. But it's not. They know it's not going to be curative, but they'll do that anyways just to buy some time in somebody who has been diagnosed with esophageal cancer. And then eventually with palliative care and hospice. These are hard cases to take care of as a nurse. They often will have an NG tube or a feeding tube, a gastrostomy tube to feed them because they can no longer get food through the esophagus. They tend to lose a lot of weight. So that's a very difficult cancer and a difficult diagnosis to have, and requires a lot of nursing interventions. And this is typically what happens is the malignancies often start, especially if somebody has Barrett's esophagus, it will start low down here right before the stomach. Or occasionally it can start up a little bit higher here. And then what they would do is they would just take this out, and if it's small enough, they can just reattach. But if it's too big and they have to take out the whole section, they take it out, and then they just have to put a feeding tube right into the stomach. Esophageal varices is another problem, and we're going to talk about this more. Esophageal varices is all over your textbook. It shows up in a bunch of different spots. Esophageal varices is very common in your patients, your hepatic patients, your patients who have cirrhosis of the liver. Esophageal varices tends to show up, so we're going to talk about it more during our hepatic week. I just wanted to show you that, again, this is an EGD looking down into the esophagus, and you see these lumps here that go down like that. Those are very large, tortuous veins. And here you can see they tend to be kind of bloody. These can rupture and cause esophageal bleeding, which can be a very, very serious situation if these rupture and start bleeding. So keep that in mind. We're going to revisit that when we talk about our cirrhosis week during liver week. This is a Skinstaken-Blakemore tube, and what the Blakemore tube is kind of like a Foley catheter, but they insert it into the esophagus in somebody who has esophageal varices that have ruptured. And the thing that the Blakemore-Stevenson tube does is you put it down the esophagus, and then you blow it up, and it tamponades, like it squishes. Let me go back one more. You would put it down here and it would squish, and it's kind of like putting pressure on an artery. It's just kind of holding pressure on it with this tube. And the balloon part sits right into the stomach like this. So you put the tube in somebody who has bleeding varices. You put it, usually you'd insert it just like a nasogastric tube. You put it down into the stomach, and then you blow up that balloon, and it tamponades down those varices, and then can prevent somebody from actually bleeding to death because now you've got pressure on there. So that's what I want you to know for chapter 46, oral and esophageal disorders. And then I'll stop here, and then I'll do another chapter on chapter 47 where we'll do gastric and duodenal disorders.